It is not even the basics. I have cut short my speech to try to tailor it down to your needs as non-intensivist. So this is just a glance to for you to be aware of what is happening around you while you're spending some time in ICU. So we are late already. I will start. I will make it short, as I said. And most importantly to me, I would like to introduce two concepts that if you understand, I think the details will not matter. And I will start with a simple question. This is the question. What are the defining or essential components of mechanical ventilation in your opinion? All these are common associations with mechanical ventilation, but which one is essential, which means that you cannot remove out of mechanical ventilation? Oxygen, pressure, airway, or sedation? Tell me what you think on the chat, please. B, C, B. Okay, there's a strong competition between B and C here. I have a D, sedation. You can choose all of the above or as many as you wish. C. Okay. No one's choosing A. Anyone more? Okay. Let's think of it. Sedation. Can you ventilate a patient without sedation? Yes, if they're highly cooperative on invasive mechanical ventilation, but more commonly on non-invasive mechanical ventilation, you would ventilate a patient without any sedation. Can you ventilate a patient without definitive airway, endotracheal tube or tracheostomy tube? Yes, again, on non-invasive mechanical ventilation. And obviously, none of you chose A, which is oxygen, because if the patient does not have any problem with oxygenation, then you would not necessarily add any oxygen above room air. So the essential component of mechanical ventilation, the only essential component of mechanical ventilation is pressure. So mechanical ventilation essentially includes pumping air under pressure. Now, if you remember the physiology, the lungs, the alveoli are always under negative pressure. During inspiration, you inhale the air, atmospheric air, under negative pressure, and you allow it passively under zero pressure during expiration. So mechanical ventilation goes directly opposite to the norm, opposite to physiology. And hence, it has an inherent harm to the alveoli, a harm that cannot be removed out of mechanical ventilation. It can be minimized, but it cannot be removed. So this is one concept to remember. Whenever you are applying mechanical ventilation, you are essentially causing some harm. It is necessary, but remember, it is harm. It applies to mostly any medical intervention, but this is very important to understand. The other concept is that mechanical ventilation is just a support. It's not a treatment. It does not treat respiratory failure. Respiratory failure is always secondary to something else. Respiratory failure is like fever. So it is secondary to pneumonia, secondary to pulmonary edema, secondary to pulmonary embolism, secondary to heart failure. So the definitive management should target the pathology while bridging this onto mechanical ventilation to avoid the patient dying while the definitive management is working. From these two concepts, we understand that mechanical ventilation does not do a dose-dependent benefit to the patient. It is not the more the better. You are not targeting a normal ABG. It will not benefit the patient in anything. So it's just to keep the patient alive. And knowing that it is inherently harmful, so you need always to keep mechanical ventilation minimal. Minimal in which aspects? In every aspect. In application in the first place, which means if the patient does not necessarily need mechanical ventilation, he shouldn't be on mechanical ventilation. Minimal in invasiveness. If a patient is suitable to be ventilated on non-invasive mechanical ventilation, he should not be hooked to invasive mechanical ventilation. Minimal in pressure, minimal in oxygen, minimal in volume, and minimal, most importantly, maybe in duration. So whenever the patient is ready to be freed from mechanical ventilation, he should not wait more. So understanding this is very important so that you know what we exactly are doing with mechanical ventilation. The second thing is just a glance about the relationship between volume and pressure in mechanical ventilation. This diagram represents the alveoli and airways. The alveoli are represented in the circle and the airways are represented in the tube. The airways, remember, during mechanical ventilation do not only include the bronchi, bronchioles, and trachea, but also the endotracheal tube or tracheostomy tube and the ventilator tubings. And the alveoli is the collection of the alveoli, not only a single alveoli. So looking at this diagram, you will understand that there are two different types of pressures generated during mechanical ventilation. One, to distend the alveoli against its or their tendency to collapse, and another to overcome the resistance in the tubes. Now, this second pressure is not, or passing the tube is just the way. The goal is to reach the alveoli and distend them, but you have to go through the tubes. Any tube physically applies resistance, and the pressure generated is the relationship between the flow, which is the amount of air you pump in a time unit, in a second, multiplied by the resistance. The resistance of any tube is directly proportionate to its length. The longer the tube, the higher the resistance, and inversely proportionate to its diameter. The bigger, the wider the tube, the less the resistance it applies. The narrower the tube, the higher the resistance it applies. So we understand that if you pump the air so quickly with a high flow, and if the tube are applying high resistance, then you will generate, or you will have to generate higher pressure to overcome this kind of resistance. Now that once you have arrived or reached to the alveoli, there's another pressure needed to distend these alveoli. And this pressure is directly proportionate to the volume you want to distend the alveoli with, and it is indirectly or inversely proportionate to the compliance. Compliance is the opposite of the elastance. Compliance is good, elastance is bad. So compliance is the ability of the alveoli to accommodate higher volume without getting higher pressure. So the better the patient's compliance, his lungs compliance, then the lower the pressure you need to generate for a given volume. The third kind of pressure that together with these two contributes to the peak airway pressure is the PEEP, which is the positive end expiratory pressure. This is the residual pressure we keep in the lungs at the minimal pressure point at the end of expiration. So during this era of modern mechanical ventilation, we stopped allowing all air out of the lung during expiration. We keep some air inside to keep the alveoli open. So this is called, this volume we keep generates pressure. This pressure is the positive end expiratory pressure. So the PEEP plus the volume divided by the compliance plus the flow multiplied by the resistance all together will compose the peak airway pressure. Now the second slide illustrates an important thing, which is what happens when the flow stops. When you have pumped all the tidal volume inside the alveoli, and stop the flow. You didn't allow it to go out during expiration. So you stop the cycle at the end of inspiration. Now there's no flow, and hence the whole flow multiplied by resistance component is eliminated. This leaves us only with two components, which is the component needed to distend the alveoli and the PEEP. This pressure is very important. We call it the plateau pressure or the alveolar pressure. It is more important to us than the peak airway pressure because it is proven, evidence-based to correlate with the patient's outcome. So the higher the plateau pressure, the worse for the patient's outcome. So this is a major goal during mechanical ventilation, to keep the plateau pressure within the limit we have found to be safe. With this introduction, we can go now more to the details. Indications of mechanical ventilation are obvious. At least the two first categories are obvious to you, which is respiratory failure, whether type 1, like in pneumonia, cardiogenic pulmonary edema, and anything like you've just heard the ABG lecture from Dr. Goltakin, or type 2, like COPD exacerbation, acute severe asthma, Guillain-Barré, and these kind of pathologies. Another category of indications is protection of airway. You need to protect airway whenever it is compromised, like in trauma, coma, anesthesia, inhalational injury, corrosive swallowing. So at this point, your goal is not actually to ventilate the patient, it is to protect the airway through endotracheal tube. And mechanical ventilation comes as an essential association with intubation then. So this is the second very common category of indications needed in mechanical ventilation. The last and very important, sometimes overlooked, is trying to balance oxygen delivery versus oxygen consumption. This happens during shock states. Shock state, by definition, you've just heard Dr. Kuhail's lecture, is the imbalance between the oxygen delivery and the oxygen consumption, where oxygen delivery falls and oxygen consumption is the same or increased. Applying mechanical ventilation would obviously improve the oxygen delivery for obvious reasons, but it also decreases the oxygen consumption. Decreases oxygen consumption through mainly two mechanisms. It alleviates the work of breathing needed by the patient now that the mechanical ventilation is in charge of the job. So the patient does not need to pay energy or oxygen to breathe. And secondly, it allows us to fully sedate and maybe paralyze the patient. So this also alleviates not only the respiratory muscles, but all the voluntary muscles. So this way you can decrease the oxygen consumption and increase or improve the oxygen delivery. So these are the main three indications under which falls many pathologies, as you understand. Mechanical ventilation, like any medical intervention, when you are starting it, you need to set your goals. And obviously, the main goals of mechanical ventilation is controlling the ABG, but as we said, you do not necessarily want a normal ABG, but you want an acceptable ABG in terms of oxygenation. And oxygenation you can manipulate through mechanical ventilation by increasing the pressure or increasing the oxygen, FI2, the oxygen concentration. Obviously, we said we want to decrease both of them. So you manipulate them in a way to keep the other targets in goals. And the other goal is controlling CO2, and CO2 can be controlled by what we call the minute ventilation. Minute ventilation is the total amount of air inspired by the patient in a full minute. So it is the tidal volume, which is the volume per breath, multiplied by the respiratory rate. So increasing the tidal volume or increasing the rate, any of them would increase the minute ventilation and hence decrease the CO2 and improve the pH. These are the two main goals, but while doing this, you need to ensure the patient's comfort. and this can be achieved by careful selection of the mode and by the wise usage of sedation and or analgesia. And while doing this, you need to always keep in mind that minimizing harm is a very important goal in mechanical ventilation, because we said it is harmful, so you want to minimize harm. These are the goals. If a patient has respiratory failure, for example, and you need to ventilate him, the first question is whether he is a candidate for non-invasive mechanical ventilation, or you will go directly to invasive mechanical ventilation. As we said, invasiveness is one thing you want to minimize, and non-invasive is always preferable if it is suitable. The problem with non-invasive is that it is not suitable for most critically ill patients, and we will in a minute show why. The very famous indications of non-invasive mechanical ventilation, and where substantial evidence is available, are three: cardiogenic pulmonary edema, COPD exacerbation, and obstructive sleep apnea. However, non-invasive mechanical ventilation is being used for many more indications, and this is based on the absence of contraindications. This makes contraindications, in my opinion, to non-invasive mechanical ventilation more important than indications. So I would say simply, with no accuracy, that whenever a patient is not contraindicated to be on non-invasive mechanical ventilation, it's worth a trial on non-invasive, but a careful trial, and we will come to that. So contraindications to non-invasive mechanical ventilation, in contrast to indications, are multiple. These are just some examples. So if a patient is not protecting the airway, this is a contraindication. A patient who is not fully comfortable or cooperative on non-invasive, any patient who has significant hemodynamic instability, significant metabolic derangements like acidosis or uremia or whatever, a patient who has excessive secretions that he cannot manage on his own, and a patient who has facial trauma or burn. These are all contraindications to non-invasive mechanical ventilation. Complications of mechanical ventilation are also multiple, and also these are but just some examples. Secondly, to the pressure on the interface, it can cause pressure ulcers. Some people develop claustrophobia. Abdominal distension sometimes is inevitable. Aspiration is a possibility, and both distension and aspiration will result in impaired nutrition. But the most important complication of non-invasive mechanical ventilation in practice, the one that we should always keep an eye on, is delaying intubation while it is indicated. This is the most harmful production or product of non-invasive mechanical ventilation. Applying non-invasive mechanical ventilation to a patient will almost always make him look better. So if you are not keeping a very careful eye on the patient, you may miss the opportunity to intubate him when he needed it, and delaying intubation is well known to cause adverse events on the patient's outcome. So this is for non-invasive mechanical ventilation. So if a patient is suitable on non-invasive mechanical ventilation, in short, he can get a trial. The trial should not be more than 2 hours, very initially, very well monitored, and with low threshold for intubation. Should you feel that the patient is not benefiting, is not obviously improving on non-invasive mechanical ventilation, then do not delay intubation. Now we'll go to invasive mechanical ventilation. And I will try to go initially very quickly through the basic modes of mechanical ventilation. There are a multitude of new modes that you will not need to know of now, but 3 are the basic modes of mechanical ventilation. These are called volume controlled or volume cycle, pressure controlled or time cycle, and pressure support or flow cycle. The word cycle means the way inspiration ends, how the ventilator ends inspiration and cycles or switches or changes to expiration. So in volume control mode, the ventilator switches to expiration when a target volume is reached. So in this mode, it is an assist control mode, which means that you get to dictate all the aspects of a breath, the volume, how much the volume is, how much the time is, how much the flow is, everything. You get to dictate this, but your goal is volume. So when you target a volume, the ventilator will push air this much volume you have required, and the pressure will be just a result of the volume you have decided. You cannot control both volume and pressure together. So controlling volume will make the pressure a consequence. You need to monitor the volume, try to limit the pressure, try to limit it to decrease the harm, but you cannot control the pressure in volume control mode. As we said, all breaths are mandatory, which means the patient can only ask for a breath, which we call assisted breath, but then the breath is always dictated by the ventilator. How much the volume, how much the time. Another popular mode and basic mode of assist control, which means all the breaths are mandatory also, is the time cycle. Time cycle means that after a given time that you get to decide when you are setting your ventilator, after a given time under a certain pressure you also set, then the inspiration ends and expiration begins. This is why we call it time cycle, because it ends after a given time. We call it also pressure control because here the target is pressure, not volume. So you inflate the alveoli to a certain pressure that you have chose during your settings. Now, choosing pressure will make the volume a consequence. It is the opposite. Again, you cannot control both. So on pressure control, you need to keep an eye on volume, but you cannot control it. Both are assist controlled modes that are suitable for starting mechanical ventilation and for sicker patients. There is no evidence-based difference between pressure control and volume control in terms of outcomes. So the difference comes from individuals and their institutional preference and protocols and experience. So you can start a patient on invasive mechanical ventilation, whether on pressure control or on volume control. The third popular and basic mode of mechanical ventilation is flow cycle. Flow cycle means that the inspiration ends when flow, the inspiratory flow drops to a certain value that also you have chosen during your set. This is called pressure support, and the word support denotes that this is not mandatory breath. It is a spontaneous mode where the patient is actually breathing spontaneously, but it is supported by the ventilator. The patient decides when to start the breath, when to end the breath, and how long the breath is, and how much the volume he will take. He will need to pay more effort to get more volume, but it is his decision, not the ventilators. So this is why this is the most popular weaning mode. It's a weaning mode. You cannot start mechanical ventilation on pressure support. You will always start it on whether pressure control or volume control. When you're weaning, then the most popular weaning mode is pressure support. This is a quick glance on the modes of mechanical ventilation. So if we have said this, now you are starting invasive mechanical ventilation. How will you initially set your ventilator? As we said, you have to choose assist control, whether volume control or pressure control, where all the breaths are mandatory, dictated by the ventilator. Oxygen, you would always start on 100%, then you can decrease that based on the patient's ABG and pulse oximetry. PEEP, the positive and expiratory pressure. Usually we would start on 5 to 8 and then adjust it based on the patient's needs. And then volume. We assume you have started on volume control. This is the commonest mode to be used in our institution in KSMC. So volume differs whether the patient has ARDS or does not have ARDS. In ARDS, it is evidence-based that lower volumes ends in better patient's outcome. So if the patient has ARDS, you would start with 4 to 6 milliliters per kg of ideal body weight. And in non-ARDS patients, you can start with higher pressures, 8 to 10 milliliters per kg of ideal body weight, usually 8. So this is the volume. As we said, the CO2 is controlled by the minute ventilation, which is the tidal volume multiplied by the respiratory rate. So the respiratory rate, you will set it after you have set the volume, because if you have chosen a higher volume, then you will need a lower rate. And if you have chosen a lower tidal volume, then you will need to apply initially a higher respiratory rate. After you've set this, you will watch the patient maybe for 15 or 30 minutes and then take an ABG. What do you monitor? Obviously, the saturation, the pressures on the ventilator, the development of something called the autopeep. Most importantly, the patient clinically, and eventually the ABG. And then you adjust according to the findings you see. These are the initial settings. After you have initiated mechanical ventilation and after you have adjusted the ventilator to the patient's specific needs, you watch. Remember that we said mechanical ventilation should always be coupled with the definitive management that is targeting the patient's pathology. As the patient improves, you should be always thinking of weaning, because we said we want to minimize the duration of mechanical ventilation as much as possible. So weaning goes into 3 steps. The first step is making sure that the initial reason for which the patient is hooked to mechanical ventilation has improved. This, as obvious as it is frequently overlooked by non-experienced operators. So you cannot jump into a weaning trial just because the ABG is good or the oxygen requirement is low or because the patient is conscious. If you have started mechanical ventilation in the first place because of severe pneumonia, for example, then pneumonia has to have proven to be improving, not necessarily resolved altogether, but improving at least in terms of X-ray, fever, shock, secretions, whatever. So this is just an example. So the cause for which you have started mechanical ventilation has to have improved first before you can even think of weaning. If this has happened, then there are a lot of conditions to meet before actually commencing the process of weaning. So you need to find out that there are no contraindications for weaning. So even if the initial cause has improved, there may be contraindications to weaning. If the patient needs high settings on mechanical ventilation, if he has significant hemodynamic instability, severe metabolic derangements, inability, if the patient is unable to protect his airway, like he's comatose, for example, if the X-ray is worsening, if he's highly febrile, if he has severe metabolic acidosis, and if he's unable to clear secretions, these are all contraindications to weaning. So an example, if the patient was initially ventilated to protect airway because he was unconscious, for example, so he's intubated and ventilated for this reason. After some time, the patient regained consciousness, and hence step 1 is fulfilled. So looking at the contraindications, maybe during this period between starting mechanical ventilation and the patient waking up, he developed, for example, ventilator-associated pneumonia, which will make the X-ray worse, the settings of mechanical ventilation higher, and maybe hemodynamic instability. So although the initial cause has improved, but you cannot start weaning now. These are contraindications to mechanical ventilation. You can apply the same concept to whatever indication of mechanical ventilation. But if there's no contraindication for weaning and the initial cause has improved, now you can proceed to step 3. Step 3 is what we call the spontaneous breathing trial. So you allow the patient to start breathing on his own spontaneously and watch him. If he does well in this during this trial, that typically should take between half an hour and 2 hours. If he does well, and I'll tell you in a minute what does well mean, then you can extubate the patient and allow him to really breathe spontaneously. As we said, the most popular mode of spontaneous breathing trials is pressure support. We usually couple it with a constant PEEP, so we call it CPAP plus pressure support. During this period, the patient is breathing spontaneously, but still on mechanical ventilation and supported by mechanical ventilation. This mode allows you to keep the endotracheal tube in and to monitor the patient well, monitor the volume he's taking, monitor him clinically, monitor his ABG, monitor his rate. And if all signs point towards the patient is able to breathe adequately on his own, then this is the time to take out the endotracheal tube and free the patient totally from mechanical ventilation. So during the spontaneous breathing trial, you monitor the vital signs, the signs of respiratory distress, his pattern of breathing, something called the rapid shallow breathing index, which has to do with the patient's tidal volume and respiratory rate. You take an ABG. If any deterioration happens during the spontaneous breathing trial, then you go back to assist control, which is volume or pressure control, the mode he was on before this trial. But if it is successful, then you can proceed for extubation now. The last section is the complications of mechanical ventilation. As we said, mechanical ventilation always carries some harm. All you can do is try to minimize it. So there are obviously complications that are related to airway. Also, there are complications that are related to sedation. These are not, strictly speaking, the complications of mechanical ventilation, but most of the time you cannot, these are common associations. But strictly speaking, the complications of the mechanical ventilation per se, something we call ventilator-induced lung injury, VILI. These can be barotrauma, voluotrauma, atelectotrauma, or biotrauma. Barotrauma obviously means harm secondary to pressure, like pneumothorax, for example. Voluotrauma means harm secondary to high volumes. Atelectotrauma means harm caused to the lungs by the cyclical opening and closure of the alveoli during inspiration and expiration. And biotrauma means the local inflammation that happens to the lungs secondary to mechanical ventilation itself and causing harm, a picture of ARDS itself. So VILI is one category of complications. Infection, ventilator-associated pneumonia or ventilator-associated tracheobronchitis is a very common and has a dreadful outcome for the patient. So also it is very common during mechanical ventilation. There are bundles that target decreasing the rates of ventilator-associated pneumonia. However, you cannot totally eliminate it. Diaphragmatic atrophy is very common. It is a relatively new concept in mechanical ventilation, but it is now found to have profound effects on the patient's outcome, and that it is happening very early on in mechanical ventilation. When the patient relies on mechanical ventilation, this inevitably causes some atrophy to the diaphragm and consequently makes it difficult to wean the patient. So these are some of the complications of mechanical ventilation. I think this concludes my speech, and your questions are welcome.